This is a Defocus Media production.
Audio Jungle.
What's up, everyone? It's your favorite optometrist, Dr. Daryl Glover.
And I'm Dr. Jennifer Lyerly, resident optometry nerd.
And welcome to Defocus Media, optometry's #1 podcast, where we discuss the hottest topics, latest technology, eyewear, practice management, and more. So sit back, relax, and defocus. Officially live.
Well, hey everybody, I'm Dr. Jennifer Lyerly, and we are talking about telemedicine. I know a lot of us were utilizing it in our practices when our offices were closed. And now that we're going back to seeing patients in the office, there's a temptation to be like, all right, let's put that back on the shelf and just see patients in the traditional way. But if you've been back in the office, you know, traditional and routine aren't really the words that we are meaning what we think they do at this point. And there's still a really strong place to utilize telehealth in our practices, even as we're returning to in-office patient care. But let's talk through what that looks like with some expert guests. Joining me is Dr. Daryl Glover, as always. Daryl, I feel like you have to say your favorite optometrist. So
hey, you know, it's your favorite optometrist, Dr. Daryl Glover, always with the big smile. Jen, today, let me tell you, it was crazy today. You know, I'm working up my own patients. I'm seeing my patients. I'm cleaning in between patients. I've never cleaned this much in my life. You know, when I'm at home, my wife treats me like a king. I don't have to do much, man. But now I have a whole new respect for anyone that does any kind of cleaning in the world. It is crazy, let me tell you.
make sure you hug your wife really hard.
Okay. Hell, shit. Excuse my language. I just went to go buy her a new car because of all the hard work that she's done. I mean, like, it's serious. This is a lot of work, but it's well worth it because I love what I do, you know?
Well, also on the show, we have Dr. Michael Samuels. He's the owner of NCI Associates in Apex, North Carolina, and a big utilizer of telemedicine in your practice.
I would say pretty big utilizer for sure. Yeah. I'm just finding, like everybody else, you know, where it fits into the practice and where it's going to stick around.
And then also joining us is Dr. Chad Morgan. He's a third-party committee member and the CAC committee leader for the state of North Carolina, and also the founder of AskTheDoc.Live, which is a telemedicine platform where patients can be personally triaged by a doctor and educated if they need to seek in-person care. And we'll talk about that a little bit more at the end of the show.
Thank you, Jen. Yeah, and like Dr. Samuels, I'm just attempting to implement this and trying to implement telehealth into our practice just as much as possible. And seeing patients, I look at a patient and see, how can I do this? How can I help this person, you know, virtually? Can I help this virtually? And I ask that question pretty much with every patient that's in my chair now.
Well, today is very special for me because, you know, I have a relationship with everyone that's on this platform right now. Chad, you, Jen, and I, we go way back to eyecare associate days. I mean, we've had some great times together. And Michael and I, we were on the leadership program in the North Carolina Optometric Society. So I'm very excited to hang out with you guys. And I know you guys have some pretty cool innovation and cutting edge technology that we're going to talk about that could really change the game for some practices today. Let's get started. Let's dive deep into it.
All right, so the first question that I wanted to talk to you guys about is, do you think telemedicine should be an important part of optometric care going forward with offices open and able to see patients?
Definitely. Yeah. I mean, I think everybody's gotten a taste of it now, all providers in eye care, really. So if there is anything good that comes out of COVID-19, it's that maybe, you know, the adoption rate of telemedicine has been sped up exponentially. So I mean, I think it depends on your mode of practice, but, you know, I mean, Chad, you can chime in too. I think, you know, with scleral lens fitting, like Chad's basically an expert in scleral lenses. I'm sure once he's got the fit dialed in, you know, there's a pretty easy way for him to provide some virtual care at that point. And maybe even if they're traveling from long distances, you know, might be able to find a way to practice more virtually. So.
Yeah, absolutely. And even in scleral care, I've even found ways to virtually connect with my patients since all of this started. You know, I had patients that we had started in a scleral evaluation and their lenses are on order and, our offices are closing. And then how do I help these people? Because these people truly are, this is essential type care and they can't see without their contact lenses. And, possibly even training online virtually, talking them through the care of the lens and different things. And as far as do I feel that telemedicine will continue in optometric care? I absolutely do. And I feel that we need to, be at the forefront of this and really implement these policies into our practice. One thing as a third-party committee leader that we're also trying to do for our state here in North Carolina is to make sure that insurance companies are going to continue to recognize this, because as of right now, we are being recognized because of crisis. And after the crisis is hopefully over and hopefully over soon, we will still be recognized to give telemedicine and telehealth type care on various platforms.
Well, I want to talk about that a little bit because, like you said, right now we're getting paid and recognized as providers for telehealth because of a crisis. But even with that being said, I'm getting so much feedback from other doctors that they don't feel like they're getting properly reimbursed for telehealth care. I posted this question on Instagram, and 100% of the people that responded to my survey said that they felt like they were not getting paid well. But then in my own practice with us utilizing it, I feel like we're getting reimbursed well, and insurances have rules in place right now where patients aren't subject to copays, aren't subject to deductibles. So It's working very well actually at the moment. What do you think is the difference where some offices seem to be getting reimbursed and other offices are saying it's not worth my time financially?
Right. So, pointing that's a good point, because I hear that a lot, because we get other providers that contact me about, how they're getting paid. I didn't get paid, specifically with UHC and with Medicaid in our state. We were really phased into this. And so now we are starting to get paid by Medicaid and get paid by UHC, and those are slow. A lot of those claims are getting processed slow. The other thing is kind of understanding what you are billing, because billing is really important for this, and understanding the modifier and understanding the place of service that you're doing this at. What I've told our clinicians in our practice is to always use we're keeping it very simple. We're using the 95 modifier, and we're using the place of service. The telephone, that's a hard one to be reimbursed right now. And we're working with different carriers on allowing optometry to be reimbursed and being a part of this, because a lot of claims are coming back and it's saying type of provider is not being reimbursed. And those are your telephones, and those are your video type calls. The other things is a lot of these practices or a lot of these carriers want the patient to be an established patient. That's a big piece of it. So if this is a new patient that is calling in and wanting to have a telehealth visit, or they're calling in and say, they have a fever, they have a pink eye, and I don't want this new patient actually to come into my practice, then I'd like to do telehealth. Well, then a lot of these carriers right now are saying, well, that's a new patient. And so we can't do new patient codes for telehealth medicine. We, as a third party in the state of North Carolina, we're working on that with various carriers right now to try to get that switched over. So there are some complications, but, on a personal note, my previous roommate, he's writing the policies right now for the state of North Carolina in telehealth. And so it's a unique situation in that he's an MD, I'm an OD, he's a psychiatrist, and he just now is finding out what we actually do for a living because he's seen it. He now knows that I may actually know what I'm talking about. He actually comes to my office now and goes, oh, this is really great technology. I haven't got this type of care. So he's actually seeing it. But whenever I speak with him about these policies and these things that are being, written, it's a way different perspective that I have now, because he works from 7 a.m. to sometimes 10 p.m. at night, taking calls the entire time. And the policy that he's writing in a matter of, 4 to 6 weeks. He said is normally policy that can take up to 2 years to set this in place. And so I'm on the other end of it. That's like, I'm pushing him. I'm pushing all these other people. And then now I actually see the real life on the other side of it. And it's not that they're anti-optometry, because they really aren't. They just aren't informed. And so our job as like the third party committee is really to give them information. And once we give them information, it's really been a lot easier to get that, to get those things reimbursed for various carriers. But it has been a process, and I think that to your question, and I think that it'll continue to be a process as this is so new. But I don't want that to, be a negative part on us pushing through. I'd say continue to use telehealth, because the more of us that are utilizing it, the more they're going to see. And even for carriers, what they then look at is, well, how many medical office visits are you guys doing for for our patients or for our customers? And they don't even know that. Those are numbers that they don't even look at. And then they look at it and they go, wait, you guys bill 99213s? We just thought that you did eye exams and glasses. No, that's not that. Well, so let's take a look at the data. Let's look at what we do. And so then that's where the communication starts. And it's actually been quite positive. It's slow for right now, but slow as a matter of 2 weeks is actually really fast. So we have had positive effects and are starting to get reimbursed by various carriers for our work.
And is this different between ODs and MDs?
I'm sorry?
As far as the reimbursements go, is that
different between ODs and MDs?
OMDs or ODs, are we getting reimbursed differently than?
Yes, it'll be different from practice to practice based off of, it's a similar same thing as, our 99213 code or 99214 code in an MD practice versus strictly an OD practice. There is going to be some discrepancy in our reimbursement on that. And I don't know for a fact, because I haven't just sat down and looked at everybody's claim, but I would think that would probably be the same with telehealth, because we're using the 99214, the 99213 just with the modifier in place. But to answer that truthfully, I can't give you exact, but I know that with the other codes that yes, that can be discrepancies. There can be discrepancies in our reimbursement.
And right now, with it being relaxed, are we able to see new patients and get reimbursement for that?
No, there are some carriers that we are definitely working on, especially in the state of North Carolina. We're specifically working right now on Medicaid. I sent UHC a letter last week, and we've been in communication with them. The other great resource for all of us is there's a resource on the AOA, and our vice president-elect, she sent us an email in response to a question that I sent to her. Very similar to that. So who is allowing new patients? Who is allowing established patients for this? And there is a link on there, and Jen, I can definitely get that link to you. I don't have it right in front of me right now, but it's a great link that the AOA has put together that shows what each insurance is doing, and they're trying to keep it as up to date as possible.
Chad, question and comment for you. With telemedicine rapidly evolving, and the whole online refraction platforms and things of that nature, at some point in time, I feel like eyecare will definitely be there. There's no doubt about it. We just we have to make sure that optometrists own that technology, right? What's going to happen with these states that have already said, oh, that's the worst thing in the world, we can't have that, it's banned, never come here? How are we going to, as optometrists, turn that around and say, okay, this is okay that we can do this now? And how's that going to play out? I mean, we're going to kind of look like we don't know what we're talking about, or what we're saying is not true, simply because at one point we were like anti-online refractions, but now we're saying, come on aboard, let's do it. How are we going to combat with that in various states and just the world of optometry in general?
Right. That's a question that I've thought about, outside of refraction in a lot of pieces of our clinic on how we treat things, because what I'm having to do now is I'm having to take a deep breath and go, okay, Wills didn't tell me to do that. Will's eye manual didn't tell me to do that. Okay, they didn't tell me to do that either. And that piece is whether it's like a hordeolum and I'm going to see back. Well, Will's eye manual tells me to see them back in 5 to 7 days. So that's what I do. I'm to the book. And now I'm thinking, okay, Will's eye manual, I'm not going to do what you say, so I'm going to have to think outside the box. I'm going to set you up for a telehealth appointment. I want to know how you're doing. You're just on an antibiotic. You're not on a steroid right now. I didn't put you on the steroid. And I'm going to kind of walk you through your symptoms right now. Yes, your eyelid is still swollen. We talked about that. We talked about how long that was going to take to get better. And so I'm thinking outside the box. I'm trying to get outside of my box. And I really feel as optometrists, we have to allow ourselves to get out of that box. And when you ask about the refraction piece, that's a big breath in for me and a big breath out and go, okay, are we really going to give this up? Am I really going to go outside of what I've been taught by the books and what I've always been clinically taught and step myself into this telemedicine piece? And for those of us that are going to really advance in this space, because telehealth is here, and like I said, I feel like it's here to stay, we have to get outside of that box and kind of make these realizations that these things are here and we can take it and incorporate it in our practice and develop it, or we may not want to do that. But the fact of the matter is that it's going to be here whether we like it or whether we don't like it, and incorporating this new technology, because technology is a big piece of practice and technology is what's really going to help practices develop.
Yeah, I've had the opportunity to sit on several boards, especially within the last couple of weeks. And the one thing that I continue to hear is that, we spend a lot of time with just gathering information. And if we actually have some technology that can actually gather this information for us, where we can actually spend more time having that conversation with the patient, analyzing that information, it could take eye care to the next level. But yeah, that may be giving up some of that refraction. That may be giving up some of those other things that we typically do that takes time in the exam room. And we just have to figure out, is that going to help take our profession to the next level? Or is it going to be one of those things that's going to bite us in the butt down the road? I mean, who knows? But we do gather a lot of information when you sit down and think about it. And it does take a decent amount of time. And for me, I feel like I'm more productive when I can actually have that conversation with my patient. I love to run my mouth. And when I'm able to do that, I can pull so much information out of my patient and then be able to look at all that information that I gathered to really give them that wow factor, but most importantly, give them the best healthcare and eye care ever.
Right.
Well, let's talk a little bit about what you guys really are doing right now in your practices to incorporate telehealth into routine care. And Mike, share a little bit about what you're doing with your office.
Yeah, so I think that I'm probably not doing quite as much as Chad is doing. I'm certainly not thinking about it. Well, maybe it does pop into my mind every time I'm in an exam room with a patient, but I mean, I kind of harken back to a patient I had last week, or I guess 2 weeks ago now. She had scleritis. So probably secondary to some irritable bowel diseases, undiagnosed. But her symptoms were really a lot like a uveitis, right? So in her description. So if I had seen her on a telemedical exam, I would almost definitely put them on a steroid, it would have been a uveitis, type of treatment, some cyclopentolate. And I want to be careful to not miss those cases, right? So, and not delay the patient's outcome. So, really in my clinic now, we're trying to kind of, make things more efficient by maybe doing contact lens check, easy fit contact lens check, patient doesn't need to come in to see me. Maybe definitely utilizing it mostly for triaging emergency visits where I never did that before. So now I actually get to see the patient in person. I can evaluate them at my own schedule on the weekend. The patients love it. They get a great experience. If it's a hordeolum, I can see the hordeolum, clear as day. So, and if I look at them and their responses and the way that, they're wincing at me, I might say, all right, I'll meet you at the office here in about 20 minutes, So I think it's great for that. I think the emergency visits is huge for me. And then again, following up with sclerals, and I'm still learning, you know, how I'm going to continue to, how this is going to continue to evolve in my practice. But that's where I'm at right now.
I think that's the key, Mike. I mean, like this is something that's brand new to us. No one has all the answers. So every day we're reaching out to colleagues. Hey, what do you do in this situation? And, you know, even our state society, they're still trying to figure it out for us as well. So I think it's safe for us not to know all the answers. And I'm very thankful for, you know, the relaxation of these policies and things of that nature as well, because it's an easier platform to actually learn on. You know, so it makes a world of difference.
Right. Well, and even if you're not getting paid for it, I mean, I think there's a benefit there. You know, I think that it's, you know, like I don't bill every time I triage a visit with a patient, especially when I go see them in the office. But I just I have a better idea of what's going on. I have a better conversation with the patient. I see the patient. I can look at them. They can look at me. It's just a more interactive way to practice medicine.
I think what's going to be so interesting is, as you guys have been in routine care, and I'm going back on Friday, so I haven't experienced this yet, but in my mind, I feel like it is going to be very hard to connect with our patients in the way that we used to. We have on a mask. There's a face shield. The patient has on a mask. Like, having a personal conversation now has a lot of barriers, and maybe better communication virtually, or you're at least seeing each other's faces move. I wonder if we're going to feel more connected to our patients through telehealth than we are through a real exam now.
It's funny you mentioned that, Jen. There's two people that have always told me this. My wife, she always says, when you smile, even though you have a mask, you can still smile with your eyes. And our chief medical officer over at my eye doctor, Dr. Artis Beatty, he says the same thing when he gives us our calls. You know, just because they can't see your face doesn't mean you can't still smile, because your eyes, you know, it glistens a little bit more. It may hit them a certain kind of way. They can tell when you're smiling, and also your tone as well. Yeah. So, yeah, the mask, I mean, I was talking about this earlier.
It jiggles a little bit.
There you go. There you go. But Chad and I was talking about this earlier. It can be pretty difficult having these conversations with your patients, because, number one, it's like you can't breathe. So you have to take a time out or step out the room and come back in. But they understand what's going on. But yeah, show that smile with your eyes, and have that right tone, and let your cheeks jiggle, like Michael said, and it'll make a world of difference there.
Right, I would agree. I just wrote, because I try to write a chat with Chad for my staff like once a month, and this month was actually it talked about smiling, and we took pictures of all of my staff in different states in their mask, whether they're frowning, whether they're thinking, all of these different states. And then we put it on the chat with Chad, and you could definitely tell which one was smiling, which one was thinking. And it was pretty interesting. And it just kind of reminds us just to kind of everyone smile in general right now. And it makes you kind of feel better. As far as like, how am I implementing telemedicine into my practice right now? I think about it. I think about it all the time. And how can I do this? A couple of interesting cases that have come to me that are previous patients, and again, they have to be previous patients, but I had a LipiFlow follow-up that normally I want to see a LipiFlow follow-up in the room. Well, my LipiFlow patient actually moved, and she moved from Raleigh to Charlotte, and she did not want to drive in, but she wanted to talk with me about what her symptoms were and what she was doing. And I found that to be pretty unique. And we had good conversation, and I kind of directed her on other things that she could do for her dry eye. And she was very pleased. And this is a 68-year-old woman, and she's telling me, you know, I have a great rapport with you. I want to keep this rapport. And I was thinking internally, this is great. I'm going to be able to continue to see patients and give patients care, in not just my patients that are here, but possibly my patients that move. I had another patient that was living in New York now and had a hordeolum, and definitely he didn't want to go and, you know, into a clinic or anything. And so he contacted me. We did a virtual call essentially, and it was fantastic. He was extremely appreciative. So there are those points that have already happened. And in the future, I think of other points that I'll be doing. I've done where patients have had, you know, blood work that we did over, like I did some thyroid panels, and I wanted to communicate those other than just a phone call. I wanted to talk to them. And so it was a virtual visit. He was very appreciative of that visit. I'm appreciative of it because now I'm getting paid for my time a lot more than what I was, because I'm making that call. I'm going through all those blood results, and now I'm doing an office visit with it and the patient satisfied because I'm actually communicating. The one thing on like triaging, and like to your point, Mike, is the big point on that is, if you do triage those patients, is to make sure that those patients don't come in within that 24-hour range, because that's one of those times, Jen, to your point, that we will not get paid for that, because they're going to see that we have billed already on the previous date of service, and then they're going to see if that was a triage. They're coming. I want to see you tomorrow. Well, we can't double bill that.
And it can be a virtual check-in, right?
Yeah.
So you still would build a virtual check-in, and obviously you want to do what's best for the patient. So if you get the patient on the screen, you need to see him immediately. But then build that virtual check-in. Now, I'm still learning the ins and outs of how that all works, but
yeah, be careful with that virtual check-in if it's within that 24-hour. That's one of the main things we've been driven in. That if you virtually check in, then that's essentially part of the same visit.
Well, one more billing question that's come up on some Facebook groups I'm a member of. There's been pushback from doctors about the legitimacy of using a 99 code if we cannot use a slit lamp, if we cannot use some of our instrumentation to assess the patient.
You're still doing external evaluation. I mean, I think that you can make the argument that, if you think you can treat it, then you're looking at them just as I'm looking at you right now, So maybe not as close as in a microscope, but I think it technically qualifies.
Yeah, I think one thing that we have to look at also is, I've mentioned this several times on various podcasts, is this device is so powerful. I mean, for someone just to be able to take a picture of their eye and then we're able to magnify that image to see what's going on. I mean, that's a powerful tool at your fingertips. And everyone knows how to use a phone for the most part. I think everyone's well-versed in taking a selfie by now. If not, there's no hope for them in life.
I mean, we can do a really good HPI, a review of systems.
Mm-hmm.
There are apps and plugins that have been verified that we can assess acuity that can go right into the platform that you're using. So yes, there's not a slit lamp, but you can do a very good external assessment. And I totally agree with you guys that using a 99 code is warranted in these cases.
Well, and you're at least asking them about their acuity, right? Like, has there been any change in your acuity? I mean, I think that is assessing the acuity to some degree. So,
yeah, it's interesting. The one thing, I mean, I know you guys are talking about how you're implementing it into your practice with return of patient care. But the other thing that I found out is just a lot of folks, they're over it now. They were trying to make as much money as they could when their office was shut down and they couldn't leave their home. But now that they're back in more of a semi-routine patient care, they've put that telemedicine to the side and they're trying to figure out how to earn in their practice right now. I mean, are you hearing that from your colleagues? I mean, Jen, what are you hearing from some of your other private practice owners? I mean, what do you guys hear in regards to that?
I think from polling people, it's about 50-50. There is a group of people who thinks that there's some advantages of trying to figure out a way to continue to work this in, especially as they're on reduced schedules right now. They're seeing a patient maybe even as slow as once an hour. You've got a lot of time to do a telehealth exam in there too, if that's the case. And then about 50% of people are like, I didn't like it anyway. I don't have the time for this. And I'm happy to get rid of it and going back to routine bread and butter, what I like doing best.
Yeah.
Which is right. It's like to each his own. You don't want to practice that way, then that's great. In my opinion, I think it can be fit into my practice in some way. I do believe, an in-person examination is king here for sure. But in certain circumstances, there are always going to be circumstances, whether a patient moves or, it's just a hordeolum, you want to triage an emergency. I mean, you could come up with vision therapy. There's so many things that you could do virtually that wouldn't require a patient to come into the office. So I'm going with it.
You could take it all across to even to the retail aspect, to show frames ahead of time so you have something put to the side for the patient when they come in. You can expedite the process.
Some utilizing Unified or some other Doxy or something like that to meet with patients before they come in, so that you already have maybe a selection of frames picked out for them.
Yeah.
Yeah.
So, Dr. Did you have anything else that you wanted to add in? Because I know you're heavy into this stuff, and you're on the state level trying to really get this moving in North Carolina. So I'd love to get your insight.
Yeah. So one thing that I have put in place, and I was on a call on Friday. It was a CMS call, and talking to other leaders, not necessarily in optometry, but in other specialties. So we talked to a pediatrics leader in Annapolis, Maryland. We talked to a hospital director in Chicago, kind of talking about what they have done and what they have implemented into their practice and how they've kept people safe. So it's extremely interesting to hear what those policies are and then what we can do. One interesting point that came out of it, because we know that, that this is a possible port of entry, and that's just came out like this past week in different studies and different data points. And we also know that conjunctivitis and pink eye is in 38% of COVID patients. So whenever we were talking with the pediatric practices up in Annapolis, Maryland, they're now having telehealth appointments for their patients. If there is a fever, there's a telehealth appointment before the child comes in. And so I looked at that, and I looked at, that statistic of, 38% have pink eye. And so when any of my patients call in and they may have pink eye, if they have pink eye, if they have a fever, now we have what's called a pink eye policy. And if there's a pink eye, we're setting up an immediate telehealth. We're not going to be bringing that patient in. So kind of to your previous question on, I'm kind of done with this right now. I did it for a little bit. I don't want to do it anymore. These are key areas where, these policies and these guidelines they're going to be good in practice, but they're also going to keep us safe. And those are kind of things that we look at kind of as state committee type things on kind of guidance for our providers, and then try to communicate as best as we can on like, what do we really need to be doing? The other thing that was very interesting that came out of the Chicago hospital, the medical director there, was that they had over 534 cases currently. And he was proud to state that none of his physicians and none of his providers, in all except for one of his 8 hospitals, had actually contracted COVID. And that was back in the beginning of March. And he said, we have a free zone. And so then we talked about what they did. They're actually treating these patients. So how do you stay safe? And those things, telehealth came in there. Doing telehealth appointments, keeping things virtual was a big piece of it. And the other piece of it was actually using PPE and how it is working to keep those providers safe. So that was kind of a safe feeling, that I received from them, to keep those things in practice for us to keep us safe. And I think telehealth is one of the pieces to keep us safe, is to do those, I call it pink eye policy, but those things that we can definitely do to utilize telehealth.
Yeah, I like that a lot. And the other thing that we have to look at is we may get hit with another wave of COVID, in the fall. So if you haven't, or if you're not taking the time to really perfect this telehealth deal, if you're not putting in procedures and policies within your office, you're going to be back in the same position that you're in now. So why not utilize this time to really hone in on your telehealth skills and really learn how to work the system and make as much as you can, but also keeping the patient first, and just take, again, optometry to the next level. This is a great time for us to be the leaders in the healthcare industry by utilizing telehealth to its maximum capability. And we can do it as optometrists because, again, we have so much that we can offer, from the external point of view to just the retail aspect of looking at frames, and just the brilliant minds that's in this profession. So I hope to see it go further, and I hope people just don't toss it to the side, because I am worried about a second wave of this taking place. And I love that concept of being able to talk to someone when I'm on call to be able to see that face, to see their eyes, instead of having to go into the office and do this, that, and the third. Because I know Jen, Chad, back in the day, those ECA days, I did not like waking up, getting out of my bed, or leaving my house to go in to see any kind of patient. So to have access to something like that is priceless.
Let's talk a little bit. I mean, there's a ton of platforms out there, and this is not going to be an exhaustive discussion, but what platforms are you guys utilizing in your practice for telemedicine?
So I think we actually use the same one. I'm using Unified Imaging. Are you using Unified as well, Chad?
I am in one of my practices, yes.
Yeah, so I am most familiar with that. I am associated with that company. And what I like most about it is it's just super easy. You know, I mean, I think that it needs to be super easy. It's great because you can, you know, have your staff member schedule an appointment for you, and you enter the room once the patient has entered the room, and it's recordable and completely secure. So, I mean, that's really what's most important, that and the ease of use for the patient. So.
Yeah, I agree. Because I'm using Unified as well, and I looked at all of these different platforms, and I wanted something that was going to be very simple because I for my staff, I want to train them on something that's very, very simple. And we have already so many systems, whether it's our billing system, our insurance system, our EMR system, our our glasses system, our order system, our gosh, you just keep going and keep going and keep going. And I don't know how to do all of the systems, and which is a problem, but I can't learn how to do all those systems. And then to bring on another platform and to bring on another system that can be tedious and can be difficult, especially after my staff have been, gone maybe a few weeks and then come back. And now we have all these guidelines for COVID. And now I need to talk to you about that. And now we're going to put into place this policy. And by the way, I need you to learn another system on top of the 4 systems that you learn. That's where I made the decision to go with Unified, because it's very simple. The patient doesn't have to create accounts. They just, send a text message and an email, you go on. It's almost as easy as you guys are out there listening to us now. But it's HIPAA compliant, it's secure. And it's when you're on there with these telehealth visits, it's literally like we're talking like this in a FaceTime. I don't really have a whole lot of time to go into like these other buttons and these other features, and it just really simplifies things for me and simplifies them for the clinic, and especially my staff.
And you can do it on both the computer web app or on your phone. So, I mean, whatever is more accessible to you. Some patients don't have a webcam on their computer, so you just let them know they can just use their cell phone. So.
Yeah. Well, we have a few comments from LinkedIn. Fernell Walker, he stated, we need help to guide the front desk team on how to triage calls more effectively with telemedicine. I think that's key. And I think, Dr. Morgan, you've really hit the nail on the head with the pink eye policy that you have in place. I mean, that is something that you work with your front desk. They know what to listen for, and they know how to move forward with that. We have another one, telemedicine is the future. Unified is free versus other 3 cost money, no profits for offices. Someone saying very true, great. So we have some feedback here on LinkedIn as well. It seems like you guys were just breaking down, one of the next questions that I know Jen and I wanted to talk about, which was some of the shortcomings. And I guess some of the shortcomings is just so many steps in regards to what you need to do when it comes to some of these telemedicine platforms. Are there any other things that comes to mind?
I mean, some of them are just so complicated. I mean, there's a billing side to them. I mean, there are multiple levels of what you have to do. And, the bottom line is with telemedicine and eye care, I still am a firm believer. It's not going to rule the way we take care of our patients, right? We're still going to take care of our patients in office. So let's make it as easy as possible so it's quickly accessible and easily accessible so that people actually do use it, right? You don't want to learn something that takes a really long time that doesn't necessarily create lots of income or might be cumbersome for you or your staff.
I think that where I draw a line is if a patient has to download an app I know personally, I do not want to download any apps that I don't absolutely have to have. And just something else on my phone, tracking all my preferences and likes. And I've seen a lot of pushback if we ask patients to sign up for a service or download an app that is going to constantly like be on their phones, then we're not going to get buy-in from our patients in the way that we need it to be to make telemedicine really work. So if it's a simple link, HIPAA compliant, obviously super important. It needs to be secure. But I can't see patients truly buying in if there's something they need to download.
Yeah, and I mean,
don't let them not have any data or memory on their phone as well. Then they're really going to raise hell with you. Like, what? You want me to buy more from Apple? I need to get that $9.99 for whatever amount of gigabytes. You don't want to cause any trouble in the office at all, you know? So I feel you on that one. People do not like to do any extra work. And Dr. Adam Ramsey always says that as well. That's why I know he likes what is it, Doxy? I think it's Doxy Me, because that one's pretty straightforward to jump on. Use that one as well. You don't have to worry about that stuff.
Yeah, and Doxy, it has a free section, and then you can like upgrade yourself up to get more stuff. But that more stuff is just more stuff to learn is really how I feel. And how I've kind of, to the LinkedIn question about like the staff part and kind of getting people ready is, you know, I do train my staff. And one of the big things is that money piece. You know, do you really feel like you would pay me to talk to me right now? You know, does the patient really feel like they're going to pay a specialty copay on that? So whenever we talk about money all the time now for that, it's whenever I'm rescheduling that 40O on, all right, well, we're going to do this visit and we're going to be able to do this online. And I make this exciting for you because now we're able to do this. We're able to utilize this platform and we haven't before. And insurance actually reimburses for that, you know, so I make it exciting, but we're going to use your insurance just like we use it in the office. I step to the staff. The staff then says, oh, a telehealth appointment. Okay, well, we're going to be using your credit card just like we're using this today, as if you're actually in the office. If you haven't done it before, you're going to really enjoy this. And then when Dr. Morgan is done with your appointment, then we're going to transfer over to check out at the front desk. At the end of the appointment, I let the patient know, okay, well, I'm going to transfer you over to our front desk. They're going to take care of the billing piece of this, utilizing your insurance and copay. So it's a constant like verbiage coming out so that they know that, because that has been something that has kicked back on us a couple times, that it wasn't worth their visit. This wasn't that he just talked to me like we're talking right now. Did I really have to pay $85 for my specialist copay? And so we've kind of use that to try to prepare instead of react. Always preparation is better than reaction.
And we have another comment here from Dr. Christy Wynn. I'll be hanging out with her this Wednesday noon on the Defocus Media Facebook page. So make sure you check us out on a new segment, Hanging with Your Favorite Optometrist. But she said, I don't know. I think having an app that's free to download will be more secure. It's also a marketing tool to push our patients to reach us through a simple app versus going to a website, which may be less secure. So what are your thoughts in regards to that?
Well, it is still an app. You know, it's still a web-based application. So it's essentially the same thing as downloading an app on a phone. It's just a website, and it is actually just as or more secure than an app itself. The problem with downloading an app, again, is that your success with telemedicine is going to be directly proportional to the patient's age, right? So like you start to tell people to download apps and do all these other things. Maybe you have to have, if they download an app, they likely have to log in. So they need a sign in or a registration. Become more to the process. When, we can just send you a quick link, you push the button and you're in the room.
I see the pro. I personally had trouble if I had something where I needed a patient to download something, 9 times out of 10, they couldn't figure it out.
Yeah. We'll have that problem with
support instead of the doctor,
It's, it just, it depends on their competency with technology, and even when you make it as easy as Unified is. So
yeah. And I like this other comment before we jump into the next segment from Fernell Walker. We've given away too many of our services over the years. We need to get comfortable with charging patients for remote care. It's okay. And I agree with them 200%.
Yes, absolutely.
I mean, as much as this is, when you talk to the doctor and get the doctor's opinion, that's a doctor's visit. And the visit via the telehealth platform or phone communication, if a patient calls in and says they want to speak with the doctor, in the past I've always been like, all right, schedule an appointment. That's how you speak with the doctor. And this is no different. You schedule an appointment via telemedicine, but talking with the doctor is subject to insurance or subject to—
you're probably going to prescribe something. I mean,
yeah.
That's what you're here for, is to get better, right?
Right.
So it's not like we're just going to chit chat, and not analyze your problem.
Well, my patients know when they come to see me, they're going to spend some money. Even if they want to just chit chat, they're going to spend some money. You know what I'm saying? Because time is precious and time is money. But now, on a serious note, excuse me?
You want a job?
But on a serious note, always put the patient first, and the money will come. But I do agree with Fernell. We really have to realize that it's okay to bill out for what we do. We go to school, we pay for all this education. Just because we're able to do things quickly doesn't mean we shouldn't charge what we're worth. Just because we know things immediately, it's just because we put all that work in the past, and now we're able to reap the rewards because we're able to spit out stuff like that. So as optometrists, as a profession, make sure you are charging, because when you don't, it impacts all of us. You can't just charge over here and not charge over there, because that's going to confuse the patient. And that even goes with being in industry when it comes to speaking for companies and things of that nature. We all have to work together as eye care professionals to make sure that we're getting our true value, because we are worth something. And I want to get my full value. Don't you, Jen?
Of course.
Oh, yeah. You know that I do.
If I'm happy to talk to everyone as a friend, but if you want a professional opinion, there are professional fees. And Dr. Nancy McCaskey here in the Raleigh was the first one who ever told me that. But we should never apologize that our services, our profession, us practicing medicine, has fees that are associated with it. So she was right when she told me that years ago.
Yeah.
All right, well, let's move into a little bit of a different concept, because one of the things with the unified imaging practice service that you guys use is that it gives you the opportunity to do something very unique, where you can see someone for special testing, visual field, OCT, and then set up a telemedicine exam, review the results, and let the patient see the actual images that you captured. And that is a service that I think has a lot of legs, especially now we're bringing patient back in to go over test results, might be putting a patient at risk of exposure unnecessarily. So talk a little bit about how you're using some of this image management functionality.
Well, I think that is definitely beneficial, that you could bring the patient in, do an OCT, or let's say they're a glaucoma patient, do the glaucoma workup, send them home, get on a telemed visit with your physician later on to review everything. But really in my opinion, what's the best about image management is the story you're able to tell in the office to your patient, right? Like all of your images, whether it's topography, wavefront analysis, corneal OCT, retinal OCT, you name it, any device in your office that produces an image can be stored in this photographic archival communication system. So when you pull it up, if you have a keratoconic patient, you might have taken an anterior segment photo with an app like MedPhoto and an adapter on your slit lamp, right? It'll populate directly in the image management system. Right next to it might be the patient's pachymetry, right? And their topography. So you are literally looking at one screen, showing it to the patient and going through all aspects of their disease so they absolutely understand it, right? So that you get better compliance in the treatment plans that you're producing, right? If you want a patient who has MGD to do LipiFlow or have IPL or whatever it might be. You need to show really good quality evidence, and there's no better way to do that than utilizing an image management platform.
Fantastic.
Yeah.
Well, I know obviously one of the really great things that you can do with the image management, you guys were talking about managing some dry eye follow-ups. And like you said, many times people do when they are seeing you for dry eye, they're wanting to talk through their symptoms, how they're feeling, and have someone there just to answer their questions. But if you can show them images that you've taken, it's such a reinforcement behind, remember, like, oh, you haven't been doing your heat compresses. Well, remember, this is why we have to look at your glands. And that kind of reinforces every step of a protocol. So
right, look at the listening green staining on your cornea. This is not good. This is chronic inflammation. This is why you have to keep taking the Xiidra even after we did the LipiFlow and the IPL. You know, it's just it just provides a really comprehensive education for the patient when they see everything side by side, and it organizes everything for the physician. So it's a no-brainer in my opinion. And now it's actually affordable, whereas like Forum and some of these other huge companies used to charge an arm and a leg for it, where hospitals could really be the only ones to access it. Now private practice can.
Well, Chad, at the top of the show, I mentioned that you just recently started a telehealth platform. So tell us about AskTheDoc.Live.
Awesome. Yeah. So it's interesting that majority of this podcast has kind of been me talking about insurance and insurance reimbursement and how to do all of this. So AskTheDoc.Live kind of flips that completely over. And essentially, it's a platform that I've created, and we just actually launched it yesterday. And it's more of a global platform for healthcare advice. And right now, that platform is just going to be centered around ocular advice, because it's just me. I'm the one that's going to be on the site, answering the calls and getting on telemedicine to kind of do what we're doing and talking about right now. But kind of to Jen's point, yeah, to my friends, sure, I'm ready to take a text message, I'm ready to take a call, and I'm ready to help you. But what the majority of the population that they don't have is that ability. They may not have a friend of a friend that has that is a doctor. They may not have a family member that is a doctor. The other thing is that, you know, unemployment is staggering right now, and it's not going to get really any better anytime soon. So people are losing insurance, you know, so they're losing all of these different ways to get care. So then what do? They self-Google, they self-medicate, they self-treat. And we know in practice that all of those things happen. It's not good when that happens. So what AskTheDoc.Live is going to allow for is for patients to come into the exam room, and as they enter as a patient, but as soon as they're in, they're a person. That's one of our big things, is you enter as a patient, but now you're a person, and you're going to get to chat with the doctor just as if you're a friend. And the platform right now is, again, it's just eyes, but we really see this being broader than that. There are platforms for just like primary care that are out there that aren't associated with necessarily my practice. So they're not associated with the hospital. This is more of a global type website that we hope, you know, offers a lot of care to people that really just need some advice. And they really just need to come on and say, hey, I have pink eye. What do I do? Okay, well, then we're going to enter a room. You're going to talk to a doctor. And then if we need to triage you to care, then we will. If we can help you with, you know, advice online, then we will. But we're really hoping that this kind of launches. And excitingly, we launched yesterday and we had 28 unique views. So it was really cool that happened in one day. And we'll see what happens, you know, in the future. It kind of started because we had to go through different unemployments, even as doctors, and a lot of you have had to do that out there as well. And it was kind of like a set around conversation. What are we going to do? And some friends and I came up with this idea, and we're going to see how it rolls.
I love that concept of just, you know, entering it as a friend, as a person, rather than my doctor hat is on right now, and this is what we're going to talk about right away. It's very important, you know, not just with telehealth, but also in the exam room to have that same hat on when you enter the room, because that relaxes the patients, and you could draw so much valuable information from the patient whenever you actually take that approach. So I love that. One question I have for you is, how about billing this out? Being that this is more advice, is this just going to be a cash paying service? That's my first question. And the second question is, what about getting sued, laws for giving the wrong advice and all that other jazz? I mean, like, how are you dealing with both of those aspects of this new business?
So fortunately, the CEO is dating a lawyer right now, so that's really helped. So we've had legal advice throughout this entire process on that, and we are not doing clinical evaluation. And so essentially, when you enter the room, you check a box. It's a disclosure box, and we're giving healthcare advice. It's not clinical treatment. It's not clinical assessment and plan. So it's very different. But when we talk about it, it goes, well, there are all these what ifs. And I know that everybody out there is going, what if, well, what if it's this? What if it's herpes? What if it's this? What if you do this and it's wrong? There's all of these what ifs. But then I also reflect on, like, how many times, kind of to Jen's point, that have I got a text message from a friend over the weekend, every weekend, that it's like from another state, that's a friend of a friend, and it's a kid's, bacterial conjunctivitis, pink eye, and they're just like, thank you so much. I'm so glad that they connected me to you and you were able to help us, and and I did it. And you all have done that out there without the actual in-person clinical evaluation, to give this kind of that advice to kind of calm people's fears, send them in the right direction, and really help people that may not be able to get help right now because of lack of insurance, lack of employment, and all those different things that are happening out there.
Yeah.
I think the key for it, Chad, that you were telling me about was that some people just don't know, do I need to see a doctor?
Yes.
And as you're talking to them as this medically educated friend service, you can tell them, hey, you do need to see a doctor. And you're not going to be practicing medicine you're just telling them and reassuring them, like, yes, you need to see a doctor if that's what's necessary. Or why don't you try some Sustain? And if it's not feeling better in 30 minutes, then you need to see a doctor, So these are the conversations that, again, we would triage ourselves via text if someone put in, or answering the phone and explain to our patients. And then if they need to see the doctor, that's when we step in as a doctor with our telehealth platforms or in-office systems. And that is, the different level of clinical assessment, and I'm prescribing things, et cetera, et cetera. So just getting that advice. That's what people are typing into Google all the time already, right? Like, do I need to see a doctor for this? Is it worth me paying my copay to get this seen? And having a medical expert instead of Google telling them, yes, this does need to see a doctor, is a really great service.
And the thing I love about this as well, Jen, is, especially from an optometrist standpoint, you can feed it back into the optometrist. That patient that has that question about the eye is no longer going to go to their primary care physician and just get that erythromycin. They're going to be able to talk to someone that's going to give them real advice and point them to the right physician to help with the problem that they actually have. Because I know we all, at least once a week, experience that. Oh, I had a red eye. I went to my primary care physician and they gave me blah, 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 blah. And we're like, why did you go there? I deal with your eyes. Come see me. Now you have this platform where it's almost kind of like Think About Your Eyes, the campaign, where it's going to help feed patients into our chairs and make things right. And I'm pretty sure you're going to open this up probably to other healthcare disciplinaries down the road as well, so that people can go in the right places as time goes by also.
We hope to. We'll see how this kind of goes. It was just kind of an idea that we've always have ideas, but we've never really done anything about it. And this one, we actually did it and toasted champagne at noon yesterday when we launched. So
be careful.
Do what?
Times, and it can be a grueling experience, but very rewarding. So congrats on launching.
Thank you.
Well, guys, thank you so much for joining us. As always, these conversations could go on forever and ever, because for everything that we discuss, there's going to be 10 more questions that come up. And I know many of you guys are going to have more questions leaving this conversation. So please share your social handles on where people can reach out and get more information or insight.
Yeah, so yesterday was my first day to set up an Instagram. I told them this yesterday. So I'm not that technology savvy, but it's interesting that I'm doing all this again. The best way to reach out to me is just my email, is what I would say. And I would email me just at my name, Chad, at AskTheDoc.Live is where I would email me.
For us, you can check out our Instagram, telehealth. That we're always posting, this is a new platform where we're posting, cases 3-4 times a week with image management involved in anterior segment photography. Or you can reach out to me at msamuels@medphotomanager.com directly. I'm like Chad. I'm not, perfect on the social media side of things. So have some other people that help us with that. So
show these guys some love. Go follow at Huddle Health and AskTheDoc.Live. Is that your Instagram handle?
That's right. Live. Yes.
Give these guys some followers.
Thank you. Yes, please.
Well, everyone, it's your favorite optometrist, Dr. Daryl Glover, and the lovely opto nerd, Dr. Jennifer Lyerly. Thanks, you guys, for hanging out with us. We look forward to hanging out with you on another show, another event. Again, Wednesday, we'll be going down, myself and Dr. Christy Wynn. We will be hanging out at noon on Wednesday. You can check us out on Facebook / Defocus Media, and also Dr. Daryl Glover on LinkedIn. We look forward to hanging out with you guys. And as always, peace and have a great one. All right. Talk to you later. Bye.
see ya.
All right, colleagues, and it's a wrap. Thank you dearly for hanging out with the Defocus Media team. We hope truly something resonated with you. And if it did, be sure to give us 5 stars and make sure you follow us on all social media platforms: Facebook, Instagram, Twitter, LinkedIn, you named it. And our handle is at Defocus Media on all platforms. And until next time, be sure to keep it 2020, and we look forward to seeing you on the next episode.